Hello, my name is Dr. David Gabbett. I'm an anaesthetic consultant here at the Trust. I've been anaesthetising for a special needs learning disability dental list for just short of 23 years. That 23 years gives me a reasonable amount of experience looking after patients with special needs. And during that time, I think I've anaesthetised over 1,000 patients. We've learnt with a lot of great deal of experience how to manage these situations and make a significant number of reasonable adjustments for what is done in patients' best interests during their admission.
Unfortunately, we're not able to do general anaesthetics within a community setting. It has to be done in a hospital setting, and some of our patients are unable to access dental treatment any other way unless they have a general anaesthetic, hence the reason why we run this list.
My name's Andrea Farthing and I work for Gloucestershire Care Services. I liaise with the staff at Gloucester Hospital because I'm the coordinator for the general anaesthetic list that we do there. This list is specifically for patients with a special need, and sometimes when they come along they need other input from other professionals, which I also help to liaise with everyone to pull this all together. I've been working closely with the team for about the last 10 years, and it does involve talking to lots of other professionals and patients and their carers.
Basically, it's for anyone that can't access dental treatment in the dental surgery, and that can be because they've got a learning disability, or they might have a mental health issue, or it could just be because they've got a medical background that makes it difficult for them to be treated in a clinic environment.
In the first instance, the dentist who sees the patient on the high street or another health professional needs to refer to the community dental service. The dentists within the community dental service then assess the patient, and if they deem that the patient requires dental treatment under general anaesthesia, they refer onto the hospital. Once the referral is then received, the patients are placed on a waiting list. I then liaise with Dr. Gabbett, our consultant special needs anaesthetist, who determines whether the patient is actually suitable to be seen at Gloucester Royal or whether we need to refer on to another hospital. I'm Funke Turner and I'm a Senior Dental Officer for Gloucestershire Care Services. I work with special needs patients in clinic, and I am responsible for the dental aspect of the general anaesthetic sessions which occur at Gloucestershire Royal Hospital. Majority of the patients that we see are unable to cooperate for their dental treatment in the dental chair. So the only way they can get their treatment is under general anaesthesia. We work very closely with the learning disability nurses of the hospital, the intensive health outreach team and other specialties.
In the first instance, when I know we have patients on the list, I ask to see the notes which are brought for me to examine. I don't think it's fair on a number of patients with learning disability to come to a pre-assessment clinic. It's very difficult to get patients out of the care facility that they're in sometimes. It's a change of routine and they find it very stressful. So I make my pre-operative assessment largely on the notes that are made available to me. I think the process really involves one of a huge amount of teamwork and communication right from the outset. So from my perspective, when the patient is deemed suitable, by looking at the notes, I'll begin a liaison with the learning disability nurses like yourself, Carol, and you may go and do a visit to the home, and there'll be an email trail which indicates how difficult and how likely it is the patient's going to get to hospital successfully, and whether or not we think about giving a pre-med via the GP before the patient actually gets to hospital. A lot of the patients find it very stressful coming to hospital. So having decided that we have a plan of action before they come, on the day is when the patients have most of the reasonable adjustments made, and it begins really with getting them onto the ward where they're met usually by Kelly here.
My name's Kelly, I am a staff nurse on the Mayhill unit. I am the link nurse on the unit for learning disabilities and mental health. I'm very interested in the learning disability side of nursing. I have become a champion for the Treat Me Well campaign, which is a campaign, and I've worked on the unit for 8.5 years, and I've been doing this list for a couple of years now. There's the maximum of 2 patients on a list, so we've got 2 side rooms that we use. We also use our procedure room, which has our recovery and our theatre all in the same area, so it's a bigger space. We don't tend to put gowns on. If the patient doesn't want a gown on, that's fine. They can go in their clothes. We don't tend to do observations because we don't want to stress anybody out.
And I think it's probably fair to say that it might not be seen good clinical practice not to do routine observations like blood pressure and oxygen saturations, but I have to make a judgment call in the best interest of the patient as to what I think is going to upset them the most and what is clinically necessary. One of my long-standing phrases to the carers is I have one rule on the list, and the rule is that there is no rules, because everything has to be done on the day in a best interest capacity and changes have to be made. So like Kelly's alluded to, it's probably not good practice not to have a name band on in hospital, but if the patient won't wear one, we have to make alternative adjustments. And reasonable adjustments include the carers having the name band, and we do identity checks with the carers. Lots of the patients will not only just not get changed, they won't actually come out of any of their clothes, they won't take their shoes off, they won't come out of their wheelchair, and it's a very difficult environment sometimes that we have to work out how we're going to get them from where they're admitted to the actual theatre where treatment takes place.
One of the reasonable adjustments that we make is ensuring that if there any other if the patient requires any other thing undertaken at the same time, then we try and get the other specialties involved. We liaise at a very early stage so that we can all be together to undertake whatever procedure the patient needs at the same time, avoiding multiple general anaesthetics.
And then it's a case of the patient going down to the procedure room. Sometimes patients don't like to go on a trolley, so they can walk down, that's fine. Usually with the carers or the parents.
Oh, I was going to ask that. Can carers stay with the patient until they have the general?
Yeah, we encourage them to stay.
And unlike usual rules of one person with somebody going to theatre, we have as many carers as is necessary.
A full examination hasn't been undertaken at the dental clinic, but we can justify a general anaesthetic because there is like tooth decay or retained roots, so the patient has had pain. Then, because we couldn't examine fully under general anaesthesia, at the dental clinic, we then consent for a full dental examination, including x-rays and any dental treatment to render the patient dentally fit.
One of the issues regarding this list that I think is hugely important is consistency of staff, that you have the same people doing the same list who know what they're doing every time. Every Wednesday we do the list.
I think it's really important to build a rapport with the patient and also the carers and the relatives as well, so that they know if they've got any questions they can come and ask me, and that's fine, and I can find out what's going on.
Little things I think make a difference. I always tell my trainees, if you've seen the patient on the ward without a hat on, don't wear a hat when you next see the patient, because they might not recognise you as being the same person. One of the things that we do that's slightly different, and again it's an adjustment to routine practice, is at the beginning of the operating list it's usual for the theatre staff, the surgeon and the anaesthetist to meet to have a World Health Organisation WHO check. In this case, on this list, we actually get the ward nurse, in this case Kelly, and the recovery staff, and any other staff who are going to be involved to come to that meeting so they understand the process that we're going to go through and on how to get the patient from wherever they may be, which is usually the ward, occasionally it's still outside hospital, and into the operating theatre successfully. So we have an adjustment to get everybody involved in the pre-dental theatre checklist. With respect to getting the patients into the anaesthetic room, a number of them do require pre-meds, medication to make them sleepy or more compliant. And this can be very difficult sometimes in terms of getting the right drug into the right patient at the right time. Kelly and I have to liaise quite carefully on how we manage these drugs and how we give them. So it's often using familiar drugs like midazolam, but some very stronger drugs occasionally, and we have to use the appropriate receptacle that the patient's familiar with. We have to mix the pre-med with something that the patient would drink, and we have to time it effectively. Some of the drugs are very powerful, and I don't like leaving the patient after we've given them, so that warrants a degree of supervision that we can't do anything else during that time period. And I think it's fair to say Kelly and I often have to go down to a vehicle in the car park, where we'll often give a pre-med actually in the vehicle, in order to get the patient in a state that's compliant enough to be brought in a wheelchair. Cannulas are not always the option. A lot of patients go off to sleep breathing gas. There may be a degree of clinical holding required in order to facilitate a cannula insertion where it's necessary. When it comes to recovery, we do like the carers or parents to be immediately available outside the recovery area, so that as the patient wakes up, pretty much within the first minute that they wake up, we bring the carers in, so that some of the first faces or voices that they hear are familiar to them.
We always make sure that the carers, parents, and obviously that we're happy for the patient to be discharged. We don't tend to keep a patient as long as we normally would keep a patient. So when they're ready to go, as long as everyone's happy, that they go home.
My biggest wish really would be a better understanding of the requirements of patients with special needs, perhaps globally within the trust and the healthcare setting. And I have numerous colleagues ring me and ask me advice on how to manage patients with their disability when they come across them on their other routine lists. And it strikes me that there's a deficit there in terms of learning and experience to manage patients with special needs on a much more regular basis.
Yeah, there's a big drive for learning disabilities, treat me well at the moment. So I think everyone really needs to get involved.
If I could change one thing about our list, it would be that we had more availability for morning lists as opposed to afternoon lists. A lot of people tell me that although they can have breakfast, it's very difficult to explain to patients why they're not allowed to have anything to eat or drink for the whole morning.
I concur with Andrea, but in addition, because these patients can't wait if they have pain, or we can't treat them in the dental chair, it really would be helpful to have an additional list perhaps every other week so we can react and respond appropriately to patients in pain.